welcome to IC, the podcast where we explore the latest advances, innovations, and insights in ophthalmology. I'm your host, Hazel, and today we have a very special guest joining us. It's my pleasure to welcome Dr. Robin Ross of Global Retina Institute.
Good
Hi, Doc.
morning.
Good morning.
I'm excited to be here and talk to you hopefully about upcoming things with Global Retina Institute. We're going to be talking today about macular degeneration, which I'm very excited about because it's the leading cause of blindness here in the United States. And we hope to continue offering innovation and new treatments to our patients.
That's so nice to hear, Doc. So, Dr. Ross had been the forefront of bringing innovative retinal treatments to patients, including one of the newest FDA authorized therapy for dry age related macular degeneration. And we'll discuss more about that, why technology matters, and which patients benefit the most, and where retinal care is heading. So, Dr. Ross, thank you so much for taking the time to be with us today, and we're excited to learn from your expertise.
Thank you, Hazel.
All right, so to get us started, Dr. Ross, could you tell our listeners a brief explanation of what dry AMD is and how patients typically react when they're told that they have dry AMD?
Well, we start screening in the United States for dry macular degeneration at age 50. Oftentimes, patients have a family history of mom or dad or a brother or sister having macular degeneration, so they intentionally come in for retinal screening. And generally, screening happens around age 50. We start screening for glaucoma at age 40. But when they find out they have the disease, all kinds of preconceived notions come to bear, and some people are very tearful, anxious. They consider it a very devastating condition to be diagnosed with, and they'll go to any lengths usually to try to prevent progression or ask for treatment. But it does provoke a lot of anxiety and can provoke some people to depression because they're worried about potentially facing blindness. We didn't have treatments for either wet or dry prior to 2004. So a lot of people are still in this generation of thinking that macular degeneration is associated with blindness. And macular degeneration is the leading cause of blindness in the United States. So getting people screened early is now becoming more apparent. And when I was interviewed for my fellowship, people asked me what condition did I want to see have the biggest change over the course of my career. And my answer was macular degeneration. I think I was the only one in my fellowship group interviewing who thought the biggest advances would come in macular degeneration because there really was nothing except age-related eye disease study vitamins. And that was the big breakthrough at that time. So we've come a long way, and I think this is an exciting time to have hope. And that's why we're here, Hazel.
That's so nice to hear, Doc. And then, so dry AMD has traditionally been a disease that we monitored rather than treated. Why has this been so frustrating to both physicians and patients, Doc?
Because we go into ophthalmology because we like to fix things. And because of its diagnostic beauty, we can actually see the retina, unlike seeing your heart. And we can look for drusen, which are the hallmark sign of macular degeneration. So macular degeneration is a disease of the retinal pigment epithelium. I like to explain it to patients as the mitochondria inside those cells are pooping out. And they're accumulating garbage, which is drusen, which is an excrescence of Bruch's membrane, which is the basement part of the single layer cell, the RPE. So the more drusen that accumulate, it's a degenerative process. The drusen then can cause atrophy, known as geographic atrophy, which is a cause of advanced macular degeneration. So dry means that there's drusen present, and the drusen are affecting the photoreceptors, basically. So the photoreceptors are the light sensing material. So that's the part of the retina that's getting sick. When the RPE can't support the photoreceptors, primarily the cones in the macula, cause decreased vision. problems with color vision, problems with contrast. Patients need more light to read with.
I see. Yes, doc. That's what I hear from most patients that I speak with as well.
So we think of it as a genetic component, but we also think of it as multifactorial, multiple factors. We now see a link with seed oils. My colleague, Dr. Chris Kenobi, in Colorado, has done a lot of historical research on drusen, and we really start to see them in the 1930s. So he's correlated with our cultural diet of seed oils, the bad oils, the canola oils, the Criscos. Crisco was produced by Procter and Gamble in the 1930s. And within about 5 years, we see drusen clinically in patients in the United States, and we have our first heart attacks. So we're learning more about seed oils, and we all need to pay attention to those. We think that's possibly correlated with early colon cancer. We
Wow.
never saw colon cancer in patients age 30 before, but we're now seeing an uptick of colon cancer and other diseases that might be affected by seed oils. So think of seed oils, ultraviolet light, high cholesterol diets, obesity and increased BMI, blood pressure, hypertension, our genetics. So all those things, or some of the things, are things we can control. Microplastics, Dr. Alan Bird's done research on some of that in England. So we have a whole host of environmental factors that also may be playing a role.
And with that said, doc, can you say that most Americans are very much aware with AMD, or is this something new that they hear about just when they're diagnosed?
Well, we have a lot of commercials now on the geographic atrophy drugs. So they associate our geographic atrophy drugs with Henry Winkler, the Fonz from Happy Days, and a guy surfing. So I think marketing, for better or worse, on television has brought macular degeneration to the forefront. Anytime we have a famous actor or actress that has a disease, that brings it to the forefront. But social media is also bringing it to the forefront. But we all seem to know someone who has it. Uh, the group in Europe that just got approval for the Primachip, they have a nice video on Science that talks about all of the physicians who are working on the Primachip know an uncle or father or someone that motivated them to work on macular degeneration. I have a family history of glaucoma, and that inspired me and to continue in ophthalmology. So we all have some connection to an eye disease, but macular degeneration seems to touch everyone.
Yes, doc, especially that it's somehow related to your diet and everything. So now that we have tackled macular degeneration, we proceed with Valeda, which is the new treatment. What exactly is Valeda, doc?
Well, Valeda is light therapy, photobiomodulation. It was FDA approved in November of 2024. Europe, of course, had approval, CE approval, in 2019, so they precede us. We got interested in it as a first treatment for dry macular degeneration. We have not had any FDA approved treatments for dry macular degeneration other than vitamins for prevention and slowing of the disease. So we got quite a bit of interest in this potential treatment in 2024 going into 2025. The first machines became available in April of 2025, and we took advantage after receiving over 200 emails from non-patients in the Southwest who were already, some of them were already traveling to Europe to get the treatment, but figuring out the logistics and who among our macular degeneration patients would qualify was the next hurdle. So now we're primarily looking for patients with early or intermediate macular degeneration who have certain visual acuity requirements, 2032 to 2070. And what this light therapy does, there are 3 wavelengths of light that a patient sits in front of. It's a very safe treatment. We're looking at 590 wavelength, which is amber, 660, which is red, and 850, which is near infrared. Those are delivered over 4 minutes, 10 seconds an eye. Their patients aren't dilated. And what it's doing is it's impacting the mitochondria in that cell layer that has the drusen called the RPE and activating cytochrome C. And that activation is referred to as photo, the light, biomodulation. And it's hopeful that that cell will produce more ATP, which is the energy, to then start getting rid of the drusen. So over the course of 6 cycles over 2 years, the study noted, the LightSight Study 3 noted a decrease in drusen volume. And the less drusen there are, potentially the less toxicity there are, and the slowing of macular degeneration, which we've not seen with any other treatment. The secondary endpoint was less geographic atrophy, which is moving from intermediate to advanced. So just to recap, there are 3 categories of dry macular degeneration: early, intermediate, and advanced. Most of the patients that are going to qualify for treatment are going to be intermediate with a specific visual acuity range. And it's that group that entered the LightSight 3 study. Now, we have many patients who come to us that are early and they still have very good visual acuity. So we talk to them about all the things they can do to slow the disease in terms of retina wellness. So this treatment is actually bringing in patients that really may not qualify for it. And if those patients choose to go through treatment, that's considered off-label because there hasn't been a study for patients with 20/20 vision or 20/100 vision. So hopefully that answers your question.
Yes, Doc. And then next question, since you tackled about which patients would be a good candidate for Valeda, Doc, how is this different from other retinal treatments or retinal injections?
Well, retinal injections right now, what we call intravitreal injections, are both for dry and for wet. So exudative age-related macular degeneration is advanced macular degeneration, and geographic atrophy, which is what we're trying to prevent with Valeda, is also advanced macular degeneration. So the evidence base is that we're trying to slow this spread of patches in the macula that are thin with no pigment or photoreceptors, which are considered patchy. Geographic atrophy is patchy vision loss. So patients actually might be looking through a McDonald's straw because of all the areas of atrophy they have. And advanced macular degeneration, we're trying to catch those patients early and treat them with the complement inhibitors. That would be either Izervay or Cyfovir. But those are all delivered the same way with an intravitreal injection. And those injections are performed for geographic atrophy monthly or every other month for the rest of their life. So the whole focus of why we have Valeda is to try to prevent patients from going into geographic atrophy.
Got that, Doc. And then if I were perhaps considered a patient, how could I not be a candidate, Doc? In case, even if I'm interested.
How would you not be a candidate?
Yes, Doc.
So you might be early, meaning you come in with drusen and your vision is 20/20. So technically the vision is 20/32. So you would be an off-label patient. So some patients, it means we don't know if treating you early is going to have the same impact as someone who's considered intermediate, but has already had some slippage in their vision.
Got that. Yes, Doc. And the big question is, would this procedure be covered by insurance, Doc?
Medicare covers if you meet the criteria of intermediate without geographic atrophy and you have vision 20/32 to 20/70. But it also does not pay for the credits required by the company who now owns Valeda. They have to be inputted into the treatment device to treat you. So
Got that. So basically, you would need to qualify the standards that they have established before it can be covered.
that's correct.
All right, Doc, that's nice to clarify as well. And based on your clinical experience, of course, since introducing Valida, what have you observed from patients who had undergone the treatment?
I think it's a very easy and safe treatment, and patients have really uh, embraced this treatment. I see a lot of hope in the patients undergoing treatment. They're doing everything as new advances come. So I'd say we launched Valeda in May of 2025. About 3 to 4 months into it, the University of Arizona Tucson introduced a new vitamin called Macular PM. So as we innovate, we encounter other innovators who introduce us to other things that might help our macular degeneration patients. So we adopted Macular PM for our patients, which is a supplement that's taken an hour before bedtime that may decrease the risk of changing over to wet macular degeneration. They've also noticed a correlation in a receptor in the RPE layer that may impact sleep, uh, may circadian rhythm, and may be a link to Parkinson's. So more studies are being done, but as you innovate, you encounter other innovators who want to collaborate. And that's, I think, giving a lot of our patients hope. But the Valeda treatment is showing a reduction in drusen for those people who qualify. There is a subtype of dry macular degeneration called pseudoreticular drusen that we discovered during another study that was being done that was higher risk, carried about a 50% risk to change over to wet. And those patients are having a remarkable response to the Valeda light treatment.
I see. And what have you heard from patients, Doc? Like, what do they really experience after the treatment? What surprised them the most?
What surprised them the most?
Yes,
Well, we
Doc.
we we do have a few patients that uh, felt that undergoing intravitreal injections for early geographic atrophy was inconsistent with their lifestyle or quality of life. They did not want to pursue that despite counseling by an outside physician, and then I was their second opinion. They did not want to do that. They are being treated with Valeda off label, and I'm really quite surprised that they feel they're getting benefit. They feel like they have less light sensitivity. Um, they require less light for reading. We think that could that be a placebo? It could be, but those few patients that are undergoing Valeda with early geographic atrophy feel like it is a positive improvement, and they've continued on in their cycles. So generally, Hazel, just to recap, a cycle is 9 treatments that are done over 3 to 5 weeks. Patients try to figure out a consistent time for themselves, but they're in and out. The goal is to have them in and out in 15 to 20 minutes. Um, but they'll do a cycle every 4 months for 2 years. And the results of the study were a one-line visual improvement uh, measured in ETDRS letters of 5.4, and a slowing down of the degeneration, decrease in drusen volume, and secondary endpoint was less geographic atrophy, less progression to geographic atrophy.
I see. Now that you mentioned that, Doc, how about for patients who just wanted to try it for the first time? Like, they just wanted to do one cycle and rethink after the treatment.
Well, we really want to know why they want to try it. It's not just like going for a ride in a car, you know. It all treatments have risks and benefits, so I'd have to really have a specific uh, person with validated drusen. So they have to have the disease. Um, I I think the parameters are set to maximize what's going to be improved. Uh, I don't think we'd have to have a case by case basis for them.
Another question that most patients would probably be asking, Doc, is, are there any risks for this treatment, or is it relatively
Well,
safe?
patients are sitting with their eyes open and closed for 4 minutes, 10 seconds. So there have been, in the study, there were patients with side effects like dry eye worsening. So we always screen everybody for dry eye. So in our clinic, it hasn't been a problem. We also have lubricating drops available before, depending on their coming in with their convertible with eyes dry when they walk in, we'll give them an eye drop. But overall, we counsel them that they'll be in front of a light. It could be drying. There's always a risk with macular degeneration that their disease could convert. Everybody has that risk, which is why in the screening exam, we'll do an OCT angiogram to make sure there's no start of wet that is not detectable before they go into Valeda.
I see. So you see patients before and after the treatment, correct, Doc?
Yes. So there
And
isn't, I see them before and after just to see if we're noticing any changes. And sometimes those changes are meaningful for the patient, even though the study was before the first treatment and after the last treatment, looking at the overall reduction volume.
okay, Doc. And to clarify as well, there is no dilation for the treatment.
That's correct. There's no dilation. We do have patients take their contact lenses out. So we have had patients arrive in their contact lenses and we have to take them out, but we do ask them to come without their contact lenses, but they are not dilated for the treatment.
I see. So that's nice to hear. So it's non-invasive, no dilation, and it only takes a couple minutes to be in the office.
That's right. They're in the office about 15 minutes if they're properly scheduled.
Okay, Doc. So question is, why is it important for Global Retina Institute to invest in technology, and why Global Retina Institute?
Well, Global Retina Institute was born after 40 years of practicing retina and ophthalmology, working in underserved areas. I've worked in 47 countries over my career, and my passion was how to exponentially deliver retina care and ophthalmology care. So back in 2016, I finished my master's in public health at Johns Hopkins, and my focus was building healthcare capacity after working on Ebola for 5 years. And what we calculated was if we train one cataract surgeon in a low income country to practice for 10 years and do cataract surgery, what was the return on that investment? And we calculated that it was $76 million, equivalent of the ROI for training one cataract surgeon. So it was much more cost effective for me to train someone here, and how to do that was the equivalent of how we train US residents and European residents is with ophthalmic simulation. So how to get that equipment and begin training took us from 2012 to 2023. So it
Wow,
was
more than
why
10
we left.
years.
It's why we left Michigan. Initially, we've had a nonprofit since 2004. While we were in Michigan, we traveled for 5 years to northern Brazil to establish setting up an operating room. And that process taught us quite a bit. That's how we developed the name Red Rover Ventures. Red stood for research, education, and development. And over time, we realized that investing in the best technology helped us deliver better care for our retina patients. So, like, we bought the first Optos in like 2008 when it came out to show people their pathology. You could show a person their tear in their retina when they had no symptoms, and you could get to treatment very quickly. They understood that if they didn't get it treated, they get a detached retina. So technology often teaches patients, whether they're from low income or from high income, it's the same, and both groups want to prevent blindness. So getting to global retina, it had to be in the name, it had to be the focus that we would deliver care internationally. And the technologies we've brought to the office have brought people from around the United States. We have patients from New York, Chicago, North Dakota, South Dakota, Durango, Santa Fe, Albuquerque. Internationally, we've had patients come for laser floater treatment. So it's symbiotic. We wear both hands, delivering care around the world. We were the first to do transcontinental laser with our colleagues in Rome because we adopted the navigated laser. It was an expensive piece of technology, and we couldn't implement it till we had 10 patients on one day. And initially, we started with 0 patients. So a wing and a prayer. The next day, a medical student walked in whose dad needed laser, and he got his medical care from St. Vincent de Paul. So I called St. Vincent de Paul, and they said, we have thousands of people that need retinal care. So the first patients that came to our practice were from St. Vincent de Paul, and they'd lost vision in one eye, and we used the navigated laser to deliver their care. And speed forward 5 years later, we're doing a research project with the Rome team on treating patients in Rome. They treated patients here in our office. Now we're going on to the next project, which is to place a laser in Tanzania. So cutting edge technology benefits many people, and it leads to great research and development of collegial relationships around the world. And that's been the joy of practicing this way and bringing patients the excellent care and research we can by developing collegial relationships. So it's a long-winded response, but many patients have been grateful and have contributed back to the nonprofit, which has been self-fulfilling. So I think that exponentially teaching and exponentially training bring exponentially more benefits to our patients through research and new technology.
That's so nice, Doc. I'd love to hear more about the navigated laser in Rome and how we can do that, but I think that's another topic to discuss. So that's another one to look forward to.
Okay, so let's plan that. That'd be part 2. Okay.
Yes, Doc. And then, since you are also considered, Doc, as one of the pioneers in innovations and incorporating technology, how has this been, especially with Valeda, how did it fit in with your overall AMD management strategy, Doc?
Well, our goal is to offer patients hope, and innovation brings the most hope. And being on the cutting edge of the next treatment that might prevent them from being blind. So all of our patients have gifts of their own. And if they can continue being a lawyer or an artist or an engineer or a teacher because they still have their vision, uh, that's exponential. So Valeda was the first treatment for dry macular degeneration, so it makes sense to figure out how to implement it. We have other cutting edge things that are coming that we are very positive about. The Dream OCT will give even better resolution to make better diagnoses. That is waiting FDA approval. We added the beacon from OcuSciences as another addendum for Valeda to try to see the function, what cells were actually being impacted, because it will pick up the function of the mitochondria. So cutting edge technology is critical. It's not always covered by insurance. And that's why, getting external support and applying for grants is so critical for us. The next big horizon is access for operations for surgery centers. The biggest crisis facing us right now is retinal detachment repair because there's decreasing reimbursement in the United States, decreasing anesthesiology. So our big project is developing an in-office operating room that will also serve our macular degeneration patients, because as gene therapy comes around and as the Prima chip gets FDA approval in the United States, being able to bring that to our patients will require the most sophisticated microscopes and the most sophisticated vitrectomy machines that will allow development of macular blebs to put in a Prima chip. So artificial vision is upon us, gene therapy is upon us. So we're living in exciting times. There are other companies that will be developing drugs that will help our patients, and we're excited about that. So thanks for having us today.
Yes, Doc. So now, before we end, since you mentioned those that we are going to be expecting, Doc, can we do like a rapid fire questions? We only have 5 minutes to answer this. So
Yes.
I think I have 6 questions that you need to answer within 5 minutes.
All right, let's go.
Okay, first question. What's the biggest misconception about dry AMD, Doc?
That all patients will go blind.
One symptom that one should never ignore.
Wavy vision. So we get a lot of calls for wavy vision. We teach patients the Amsler grid developed by Mark Amsler with the dot in the center and the straight lines. But patients need to kind of vigilantly check their eye one eye at a time. The Amsler grid isn't meant to be a 10-hour crossword puzzle. It's really meant to be somewhere where you check the same distance each day with your reading glasses on if you require them. Just make sure the center is straight and not wavy. But many patients will call in and say, I've got this wavy vision or I can't see my spouse's face. Well, when's the last time you looked? Oh, it's been weeks. I haven't checked the Amsler grid. It's kind of like
Yeah.
our Chalazion patients not doing their heated compress. And I say to them, well, would you go 3 weeks not brushing your teeth? So that's the probably most frequent thing they should never ignore.
Okay, and how often should people over 60 have a retinal exam, doc?
Well, they should have, if they've had an exam at age 50, really it's at the discretion of their primary eye care doctor. If they have an eye care doctor, like an optometrist or ophthalmologist, they should get checked once a year. I think the current recommendation is every 2 years at the latest if they don't have anything going on. But I think at age 60, they should get checked once a year.
What's one habit that supports long-term retinal health, doc?
Your diet. You know, if you start early, many of us start late checking things, just because you bought organic chips at Whole Foods doesn't mean they don't contain seed oils. So all of us have favorite things. And if we start looking at the routine things we buy and go, oh my gosh, it's got canola oil, it's got this. If we start early paying attention to the things we eat, because food really should be have a nutritional component. And not everybody has access to good nutrition, but looking at farmers markets, looking at all the good things we can eat, trying to eat better is the one, I think, best evidence we have for healthy retina. Having careful retinal screening. Many of my patients, we check the retinal periphery for other pathology like lattice degeneration, which 10% people have. And we try to give them a whole fitness program for their eyes. Like, you need to take care of your eye surface. Do you want to operate in a clean kitchen or a dirty bathroom when you have your eye surgery? That we try to give people a whole front to back. This is what you need to do to have healthy eyes. Because I think nobody wants to lose their vision. The two things Americans fear the most are getting cancer and losing vision, going blind. So some of that goes back to our diet. And so I love my potato chips, but now I gotta look to see if they have,
Eat your
if they have
vegetables, doc.
seed oils, and I have to eat more fruits and vegetables.
Yes, doc. And what technology are you most excited about beyond Valeda?
I'm really excited about the new OCT called the Dream OCT by Intralight. I think that's going to give an entire picture of the eye, a picture of the cornea, the lens, the anterior chamber, the retina, the choroid, OCT of the whole retina. I think I'm pretty excited about that. But I'm also excited about virtual reality ophthalmic microscope that has intraoperative OCT. That's by Zeiss, the Artivo 850, which is going to scan the macula after macular surgery while the patient's in the operating room to make sure everything was done. So for macular hole patients, for macular pucker patients, that will be innovative.
And last question, doc. What's the most rewarding part of being a retina specialist?
I think it's restoring vision, is seeing patients get their vision back. I think the most frustrating thing is access. As you know, we had a patient not too long ago, a veteran, who was referred to us by Honor Health for a detached retina. And Sherry and I came in and saw him on a Saturday, but we couldn't get an operating room. And his pupil didn't dilate, so he really wasn't a great candidate for pneumatic retinopexy. But we ended up doing one anyway because it was 5 days before an OR would open up. And he did great. Remember, he had a macula off detached retina by the time we saw him, and it was his better seeing eye. So we ended up doing a pneumatic retinopexy. And the great thing was he was a great swimmer. So he could flip in the office, and we had him putting his head down, and because he had tears up above and down below. And usually tears down below are not a good candidate for retinopexy, but Thankfully, we have indirect laser, we have cryopexy in the office, so we were able to fix him, and he ended up having a great outcome, and his vision came back to 20/25. But that's the sad part. When you can't get what you think the patient needs right then and there, that's the struggle. That's the thing that keeps us up at night.
So we completed that rapid questions.
Oh, thank you, Hazel.
Before we close, Doc, last message. If there's someone listening who has recently been diagnosed with dry AMD, what would be your message to them?
Go to the doctor that gives you hope and make sure they show you your images, make sure they explain things to your satisfaction, and don't ever give up. And keep marching forward and learning as much as you can to keep your disease at bay. Because remember, and this is what I tell Valeda patients, even if you do Valeda, that's a short period of time. 2 years is not forever. There's going to be other great things coming down the pipe. So don't give up and don't stop doing what you need to do.
That's nice, Doc. I think that wraps up our topic for today, and we hope to see you again soon, Doc.
All right. Thanks, everyone.
Thank you, Doc.
See you back in the clinic. Bye-bye,
See you,
Hazel.
Doc. Bye-bye.